many of you have had a patient or a colleague roll their eyes when someone mentions mindfulness for pain? I get it. The word has been co-opted by wellness culture, slapped on candles and apps, and sometimes delivered to patients in a way that kind of makes them feel like we're saying, this is all in your head. Let's just teach how to breathe through it. And that's not what we're talking about today. Today, I want to show you what the research actually says about mindfulness and pain, not the watered down version, but the neuroscience, how it works in the brain, why it produces analgesic effects through pathways that are completely independent of opioids, and how little it actually takes to start seeing results. Because here's the thing that surprised me when I dug into the dose-response literature. You don't need to turn your clinic into an ashram. The evidence shows that even ultra-brief mindfulness, we're talking a single 15-minute session, can produce analgesic effects that rival low-dose opioids. Let's unpack that, and starting why this works at all.
This is the Modern Pain Podcast with Mark Cardula.
Before we get into the studies, let me name the elephant in the room. Most of us weren't trained in this. Physical therapy school, I can only speak for, but it gave us biomechanics, anatomy, exercise prescription, manual therapy, all of course valuable. But when it comes to the psychological dimensions of pain, many of us were left with this kind of vague sense of that we should address it, but really without any significant tools to do so. And then there's that practical barrier, right? You got 30 to 45 minutes. If you're lucky, you're managing a caseload. The idea of adding a full 8-week mindfulness program on top of everything else feels impossible. And honestly, there's a credibility barrier too. A lot of us worry that if we start talking about mindfulness, we're going to lose the trust we've built as clinicians who deal in real interventions. We don't want to sound like we're handing patients a crystal and tell them to visualize their pain away. So what I want to do today is reframe this with the neuroscience. Mindfulness isn't an add-on program you need to become certified in before you can touch it. It's a clinical skill, a set of techniques with a dose-response curve, just like exercise. It has identifiable neural mechanisms, and just like exercise, something is dramatically better than nothing. Before I show you the dose-response data, I want you to understand why mindfulness produces analgesic effects at all. Because once you get the mechanism, the clinical application becomes obvious. There are several things happening in the brain during mindfulness that are directly relevant to pain. Let me walk through the ones that matter most for clinical practice. Mechanism 1, separating sensation from suffering. This is the big one. Pain has two components that the brain processes through distinct pathways. There's a sensory discriminative dimension, the what, where, and how intense information processed by the posterior insula, thalamus, and somatosensory cortex. And there's the affective evaluative dimension, the how bad is this? What does this mean? Should I be scared? Processed by the anterior cingulate cortex and the prefrontal regions. In normal pain processing, these two dimensions are tightly coupled. You feel the sensation and you simultaneously experience the suffering. They arrive as a package deal. What the neuroimaging research shows, and this comes from Gant and colleagues in 2011, Gard and colleagues in 2012, and Zeidin and Vago's 2016 mechanistic review, is that mindfulness decouples these two streams. Experienced practitioners show increased activity in the sensory processing areas, but decreased activities in the evaluative appraisal areas. So these studies show that mindfulness practitioners show higher sensory cortex activation, but lower prefrontal evaluative activity during pain, decoupling ouch from the oh no. Pain and pleasantness drop by 22% despite maintained sensory processing. Think about what this means clinically though. The patient still feels the sensation. We're not numbing anything, but the catastrophic narrative, the this is terrible, it's getting worse, I'm never going to get better, gets disconnected from the raw sensory input. They can experience the sensation without the suffering spiral. And if we think about that, this maps directly onto ACT-informed care. We're talking about diffusion, unhooking from the story the mind tells us about the sensation. The neuroimaging is showing us what diffusion looks like at the neural level. Mechanism 2, the letting go paradox. Here's where it gets really interesting and honestly a little counterintuitive. When most of us think about managing pain, we think about control. We think about distraction, suppression, gritting through it, or trying to relax in order to make pain go away. These strategies involve high cognitive control, the lateral prefrontal cortex working hard to suppress and override the pain signal. Mindfulness does the opposite. The neuroimaging studies show that during mindful attention to pain, experienced practitioners actually show decreased activity in the lateral prefrontal cortex, the brain's executive control center. They're not fighting the pain harder, they're fighting it less. So Gard's study in 2012 showed during pain, mindfulness practitioners showed decreased lateral prefrontal cortex activity, less control effort, combined with increased posterior insula and somatosensory cortex activity, more sensory processing. The result was less effort and less suffering. And this is the paradox. By allowing the brain to feel the sensation more fully, higher sensory activity, and fighting it less, lower prefrontal control activity, the subjective experience of pain drops. You could call this dropping the shield. The arrow of pain still lands, but it doesn't carry the poison of suffering. And the reason is that the suffering was never coming from the sensation itself. It was coming from the brain's resistance to the sensation. Now, this has a huge clinical implication. How many of our patients have you seen try to relax their way out of pain? They're lying on the table, jaw clenched, trying so hard to relax, and it doesn't work because relaxing in order to make the pain stop is a control strategy. The desire for relief itself is activating the resistance network. Saying try to relax and let go of the pain is a control instruction wrapped in mindfulness language. True mindfulness cueing sounds more like notice the sensation, you don't need to change it, just let it be there. The distinction matters neurologically, and this is how we have people practice it with an ACT-informed lens. James Murph and colleagues in 2025 clarify this as active acceptance versus passive resignation. It's not giving up, it's an active willingness to let the sensation exist without needing to fix it. And paradoxically, that's when the nervous system settles. Let's talk about mechanism 3, thalamic gating. The thalamus is essentially the brain's switchboard. All sensory information from the body passes through the thalamus before it reaches the cortex for conscious processing. Zeidman and colleagues in 2011 had fMRI work that showed that mindfulness meditation deactivates the thalamus during pain. Let's think about what that means. Mindfulness may be functionally filtering nociceptive information before it even reaches your conscious awareness. It's not just changing how you think about pain, it may be changing how much nociceptive signal gets through in the first place. In Zeidman's 2011 study, mindfulness meditation deactivated the thalamus during noxious stimulation, suggesting a gating mechanism that filters nociceptive signals before they reach cortical processing. For those of us with a manual therapy background, this should sound familiar. We've talked for years about closing the gate at the spinal cord level with the gate theory. This is a higher order version of the same concept, gating at the thalamic level, driven by a cognitive technique rather than a peripheral input. On to mechanism 4, turning down the threat alarm before it fires. This one is huge for chronic pain, and I think it's underappreciated. In chronic pain, a massive part of the suffering happens before the pain even occurs. The brain's threat detection system, the amygdala, the anterior insula, the salience network, starts firing in anticipation of pain. Patients brace, they guard, they catastrophize, and the nervous system ramps up before anything has actually happened. Lutz and colleagues in 2013 found that expert meditators showed reduced baseline activity in the amygdala and salience network prior to a painful stimulus. They weren't bracing, they weren't pre-suffering. And here's the clinical payoff. When the pain actually arrived, these practitioners had a stronger initial sensory response, but much faster neural habituation. Their nervous system processed the pain and moved on, rather than getting stuck in a loop of alarm and amplification. Think about your chronic pain patients. How much of their daily suffering is anticipatory? The fear of bending, the dread of a flare-up, the anxiety about whether today will be a bad day. That anticipatory threat processing is amplifying their actual pain experience. Mindfulness directly targets this circuit. This connects directly to graded exposure work if we think about it. Mindfulness can serve as a pre-exposure tool, helping patients approach their feared movements with the reduced anticipatory threat activation, which makes the exposure itself much more tolerable and more likely to produce positive learning. Mechanism 5, from story mode to sensing mode. Farb and colleagues' work described a shift that I think every clinician has seen in their patients, but you may have not had the language for it. There are two modes of self-referential processing in the brain. The narrative self, mediated by the dorsal-medial prefrontal cortex, it's the storytelling mode. It's the voice that says, my back has been bad for 10 years, my doctor said I have the back of an 80-year-old, I'll probably need surgery eventually. It's thinking about the body and the pain. The experiential self, connected to the posterior insula and primary interoceptive cortex, is the direct sensing mode. It's the raw, moment-to-moment experience of what's actually happening in the body right now, not the story, the sensation. Farb's work looked at mindfulness training and how it reduced dorsal-medial prefrontal activity, the narrative self, and increases posterior insula connectivity, the experiential self, shifting patients from thinking about pain to feeling the body directly. Mindfulness training shifts activation from a narrative mode to an experiential mode. And this matters enormously for chronic pain because so much of what sustains chronic pain isn't the moment-to-moment sensation, it's the story wrapped around it, the diagnosis, the prognosis, the identity of becoming a pain patient. When patients learn to drop in experiential processing, what the literature calls bare attention, they often discover the actual moment-to-moment sensation is much more manageable than the story made it seem. This is one of the most powerful reframes you can offer a patient. Right now, in this moment, what do you actually feel? Not what do you think about your pain, not what has it been like this week. What do you feel right here, right now? That question is a mindfulness intervention in itself. Mechanism 6, non-opioid analgesia. Now, here's the one that should really get your attention as a clinician. Most pain relief strategies, placebo, distraction, even some pharmacological approaches, work through the brain's endogenous opioid system. Zeidman's group tested this directly by administering naloxone, an opioid antagonist that blocks Zeidman's group tested this directly by administering naloxone, an opioid antagonist that blocks endogenous opioid activity, during mindfulness meditation. The result? Mindfulness still reduced pain even with the opioid system blocked. So with this not eliminating mindfulness-based analgesia, this confirmed that mindfulness works through a distinct non-opioid cognitive regulatory pathway. This is mechanistically different from placebo, distraction, or sham meditation. This is not a placebo effect. This is not endorphins. This is a distinct cognitive self-regulatory pathway that operates independently of the opioid system. And the clinical implication is significant. For patients who are opioid tolerant, or who are tapering off opioid medications, or who simply want non-pharmacological options, mindfulness engages a pathway that is mechanistically separate from what their medications are doing. It's complementary, not redundant. Our last mechanism 7, better body sensing, better emotional regulation. This is the last mechanism I want to highlight as it ties everything together, and it's particularly relevant for the patients we see who really have difficulty distinguishing between physical sensations and emotional states. Mindfulness improves what's called interoceptive accuracy, the ability to accurately detect and interpret signals from the body. Lazzarelli and colleagues in 2024 showed that this improved body sensing is directly connected to better emotional regulation. What they found was that mindfulness improved interoceptive sensibility and connected body awareness to emotional regulation. Patients learned to distinguish physical sensations from emotional states, preventing somatic emotional spiraling. Let's think about the patient who has a tight chest and immediately interprets it as something is wrong. Here's understandable anxiety, which tightens the chest further, which confirms the fear. That's a somatic emotional spiral. Mindfulness breaks that cycle by helping patients notice the physical sensation accurately without the automatic emotional interpretation. This is closely related to what the literature calls an equanimous attitude, the ability to observe body sensations with balance and non-reactivity. It's not indifference. It's a skilled, trained capacity to feel what's happening without being hijacked by it. So let's step back after all these mechanisms and look at the full picture. Mindfulness isn't doing one thing. It's simultaneously decoupling the sensation from suffering, gating nociceptive signals at the thalamus, reducing anticipatory threat processing, shifting patients from narrative to experiential processing, engaging non-opioid analgesic pathways, and improving the accuracy with which patients read their own body signal. This isn't a soft intervention. This is a multi-mechanism, neurobiologically validated approach to pain modulation. And it's something you can start delivering in your next session. Okay, so that's what's actually happening in the brain when someone practices mindfulness during pain. It's not relaxation, it's not distraction, it's a multi-mechanism process that decouples sensation from suffering, gates pain signals at the thalamus, quiets the threat alarm before it fires, and engages analgesic pathways that are completely independent of opioid. That's the why it works. But the question you're probably asking is, how much does it actually take? Do patients need an 8-week program? Can a single session in your clinic make a real difference? What's the minimum dose that actually moves the needle? That's going to be part 2, and the answer is going to surprise you because the threshold is much, much lower than most clinicians think. Make sure you're subscribed so you don't miss it, and if this episode helped you see mindfulness differently as a clinical tool, share it with a colleague who could use it, and I'll see you in part 2.